The preparation for administering a spinal anesthetic is full aseptic technique. This includes a hat for your hair, it includes a mask, and it includes a sterile gown. Safety eyewear is optional if you're worried about a splash into your eyes. And you need to take time to ensure that when you scrub, you're scrubbed in an appropriate manner and that you are aseptic when you're putting on your gown. So we have our sterile pack. We can see that it's been autoclaved and it's only 1 day old. You can open that first. So inside the sterile pack we have some paper towels for drying your hands if you have a gown inside the pack. We have our drapes for ensuring sterility. We then have 2 small containers that we can use to fill with chlorhexidine for cleaning, and you can use either the cotton wool balls or you can use the gauze. And then we have a swab holding forceps that you can use to clean with. So it's important with your sterile field to ensure that you don't get chlorhexidine onto your needles and syringes. So we divide the field into 2 sections. We have a section here where we're going to have chlorhexidine, and then we have a section over here where all of our sterile clean equipment is going to be placed. When we receive the chlorhexidine, we receive it off the sterile field so that there's no chance of any drops landing onto our green drapes or onto our instruments. We can then place our gauze into the chlorhexidine solution. It's also important that you don't get the chlorhexidine onto your gloves because you're going to be touching the needles and the syringes. Before we administer the spinal, we ensure that our patient is in the correct position on the table. So she must be sitting upright with her neck flexed, and we ensure that the drip is still running while she's in this position, so we can co-load her with fluid. It's often useful to have a pillow on the patient's lap that she can hold and bend her shoulders around and bend forward. While we're cleaning the patient, we ensure that our chlorhexidine area of our sterile field is closest to the patient, and that when we throw away the swabs, we don't have to move over the sterile field as we throw them away. So we have our bin close to the patient as well. When cleaning the patient, we clean in a circular manner from inside outwards, an increasing circle size. And it's important to try and limit the amount of chlorhexidine that drips down the patient's back into her natal cleft, as this can be a risk of fires when using the diathermy, and it can also contribute to hypothermia on table. We clean the surgical area 3 times with the chlorhexidine swabs. One has to wait for the chlorhexidine to dry before administering any of the local anesthetic or the drugs. The anesthetic assistant is now giving me the sterile needles and syringes. I'm assisting her in ensuring that all of the equipment is sterile. We have a 5 ml syringe for administering lignocaine to the skin. We have a green needle for drawing up the lignocaine and a blue needle for administering it into the skin. We then have a 3 ml syringe for the bupivacaine fentanyl mixture that we're going to inject into the spinal space. We use a 25 gauge pencil point needle for the spinal anesthetic. It comes with a stylet, and it's important to count the sharps. So we can see we have 4 sharps here that we're going to use during this procedure.
It's IV lignocaine 2%, and expiry date is 2030.
So I'm using now the 5 ml syringe and the green needle to draw up our lignocaine. When finding the appropriate space to inject the spinal anesthetic, one feels for the tops of the iliac crests on each side. This line between these iliac crests is called Tophier's line, and it normally goes through the L4, L5 interspace. So if we can feel at the L4, L5 space. We then make sure that we're in the midline by feeling the vertebral processes. Or I can make a mark there with one's finger. We then administer the local anesthetic to anesthetize the skin. Just warn the patient before you do this. Okay, my dear, I'm just going to give you a small jaw vac. There you see. Watch as the bleb forms. We've now finished injecting the lignocaine into the skin. I'm going to keep my needle, but I'm going to put it on the side of my sterile field so that I don't confuse it with any of my equipment that I'm going to use for the spinal injection. I've used this green needle to draw up the lignocaine, so I'm also going to put it to the side, and I'm going to use my introducer needle now to draw up my bupivacaine and my fentanyl.
Okay, this is heavy marking, and expiry date is 2014.
It's important to shake the ampule before drawing up the bupivacaine, because the dextrose and the bupivacaine are of different weights, and so they settle in the ampule at different levels. So to get a good mixture, you need to shake it first. We draw up a total of 1.8 mils of the heavy bupivacaine, and we're going to add to that 0.2 mils of fentanyl. So our total volume will be 2 mils.
This is fentanyl. Expiry date 2016.
Throughout the process of drawing up our drugs, we ensure that we keep the chlorhexidine separate from the area where our needles and drugs are. For giving the spinal anesthetic, I have my introducer, my spinal needle, and my bupivacaine fentanyl mixture here. I have no other syringes and needles on my sterile field, so there's no chance of confusion or giving the wrong drug. I insert the introducer needle through the point that I previously marked in the intervertebral space. And initially one starts off horizontally. Insert the needle, the introducer needle, through the supraspinous and the interspinous ligaments. If one encounters bone while inserting this needle, one can then slowly change the angle more cephalid and insert the needle further. As I insert the spinal needle, I have a little bit of counter resistance here with my hand so that I know that I'm not inserting the needle too quickly, and I'm feeling for the loss of resistance as I pass through the various ligaments. If I think that I'm in the correct space, I can remove the stylet and watch for the backflow of CSF. If there's no backflow, I reintroduce the stylet and I insert the needle further. Here we can see that there's now a backflow of CSF, and I want to assess the quality of the CSF flow. We can see here that there's a good drop rate, so that would mean that I'm well inside the intrathecal space. One can also rotate the needle 180 degrees, and now the flow continues, which means that I'm definitely inside. When injecting the local anesthetic, it's important to stabilize the spinal needle. One doesn't have to stabilize the introducer, just the spinal needle. So I have some counter resistance on the patient's back, and I hold the hub of the needle. One then attaches the syringe firmly, and one then aspirates just 0.1 mil, just to ensure that there is mixing of CSF with the bupivacaine, and one can see the turbulence in the syringe. And then one injects slowly over about a 20-second period. Halfway through the injection, one can aspirate another 0.1 mil again, just to ensure that the needle hasn't moved. We can see there good mixing, and then finish the injection. All the equipment can then be removed in one movement. And the sharps can be placed on the sterile field. At this point, it's important to pay attention to your patient, and one can deal with the sharps and the equipment later. We spray some Opsite spray to seal the wound. We're now going to slowly lower the patient onto her back. We have the neck area flexed to prevent a high spread of the spinal anesthetic. Going to lower her down slowly. And as soon as she's lying on her back, it's important to insert a wedge under the right hip to prevent aortocardial compression. At this point, monitoring of the patient and communication with the patient becomes essential. So we're going to start the blood pressure on automatic cycle of cycling once every minute. And at the same time, we're going to continue to talk to the patient and make sure that she's feeling okay. How are you feeling, my dear? You must tell us if you feel like vomiting or you feel dizzy, okay? The early signs of spinal hypertension are a patient that is not talking, a patient that complains of dizziness or of nausea and vomiting, and this is an indication to give your ephedrine or phenylephrine immediately. You don't have to wait for a low blood pressure on your monitor before giving those drugs. After delivery of the baby, the obstetrician is going to ask you to give Syntocinon. We give a total bolus dose of 2 to 3 international units. You don't have to give the 2 to 3 units all at once. You can give smaller boluses and titrate it to effect. So I've given a 1 unit bolus, and after a couple of minutes I will give another 1 unit bolus if it's needed. We then add 20 units of Syntocinon to a 1 liter bag of fluid and run that at 125 mils per hour. So you can run that in over 8 hours.